Hi, and welcome to another ICS Impulse video. I'm Wendy Crumley-Welsh, the product manager for ICS Impulse. Today we're going to be talking about doing the Headshake test. Now this test isn't in the default test battery for the ICS Impulse, but it's very easy to add this test in and perform it if you want to do so. So the Headshake test provides the ability to diagnose unilateral vestibular disorder. The purpose of this test is to identify nystagmus that is evoked after shaking the head and abruptly stopping. The Headshake test determines if there's presence or absence of headshake nystagmus by recording the patient's eye movement during the maneuver. This test must be performed using a vision-denied solution. The patient is sitting. You grasp the patient's head and move it quickly side to side at approximately 2 Hz and with an amplitude of approximately 30 degrees to either side. Perform 20 cycles and then abruptly stop. The eye movement should be measured to determine if nystagmus is present or absent after the head movement stops. So regarding pupil detection, calibration, and the vision-denied solution, all these things are covered in other videos, so we won't be talking about those today. Couple of things. Goggle placement. You need to tighten the goggles so that they stay on during the maneuver. So you want to make sure that the goggles are not slipping, you're not touching the goggle strap or the goggles during the head shake maneuver. The eye video recording, whether you use grayscale image or pupil location to set your thresholding, the eye video recording will always be in grayscale, and I'll show you that during playback. The other thing is you can use a synchronized room video when doing head shaking. That means you can actually video the person as well as the patient's eye from the camera and the goggle. And then the last two things, external monitor and presentation remote. You can, by clicking this little button here under external monitor, put the eye up on an external monitor as well as the slow phase velocity. And then the presentation remote, you can use that to start and stop the test. Let me talk to you about creating a test in the OtoSuite vestibular software. So basically you have a lot of options under dynamic positional, so you can use one of those. So in this example I decided to use Hallpike Stinger. So if I wasn't doing a Hallpike Stinger test in my clinic, then I came in under test options and I renamed it to Headshake. I also came over here and chose synchronized room video because it wouldn't make sense for me to use head position feedback that have the positions for Hallpike Stinger in them. So I want to use the synchronized room video. You can set up what the maximum duration of the test is, and you can just set up whether you want to display horizontal and vertical traces. So once I rename it, under dynamic positional, I now have Headshake in that second position where Hallpike Stinger used to be. And then I would recommend just on the drop-down list, just choose head straight. This drop-down list does still apply to Hallpike Stinger, but just choose head straight and it will be fine. So you want to instruct the patient that you're going to shake their head. You want them to just try to keep their eyes at a central position. And then when you're doing the head shaking and afterwards when you're measuring the nystagmus, you will have a real-time SPV value here as well. And to learn more about the real-time SPV, in the manual, in one of the appendices, it explains the real-time SPV and the SPV algorithm. And then at the end, you will have the data analysis. So you're going to see when you're shaking the head, the eye is also going to be moving from side to side. So you will have these spikes here from the eye movement. This is the horizontal eye position trace. And then once the head shaking stops, then you're measuring the nystagmus. So this is a normal person. So this is during the head shaking, and then this means there's no nystagmus once the head shaking had stopped. And then this is your vertical trace. And so here you see your SPV. Well, because some of these spikes look similar to nystagmus, it did pull out some slow phase velocity degrees here, and then the vertical is fairly flat. Now I will show you what to do about your analysis here. You can actually go in and set your cursor to where you want the analysis to begin. So let's say we want to ignore all that while I was shaking the head, and I want to just start the analysis where the head was stopped. So I place my cursor there, and I click Reanalyze from Cursor. And now I have the trace, so this trace here, horizontal and vertical trace, and then my horizontal and vertical beats. And what we see here is there was no nystagmus. And we can see that in the trace as well as in the SPV graph. And then let's show you playback. So let's switch over to the software And I'm going to play back this video. Now, I actually did the head shake maneuver on myself, but you're going to see the eye trace here. And now I have vision denied on, so I have the vision denied cup and patch on, as well as the goggles. So I can't see anything. And you'll see the eye video here, the trace, the SPV graph, everything will play back together. So we're actually going to play the full trace. So I'm going to uncheck play from cursor. Click play, and you can see that everything is synchronized together. The room cam, the eye video, and the trace and the SPV graph. So I'm shaking, shaking, shaking the head. And then you stop and measure any nystagmus present. Now, obviously, when you are not performing this on yourself, you can more vigorously shake the patient's head. And that's the playback. So what do you see down in head shake info? You have the name of the test, so head shake, head straight, vision denied, the name of the operator, the calibration, the test date and time, how long the test took, where analysis begins. So since it says 14 seconds, that's because I did the analysis after the head stopped moving. Then the peak SPV down here, 1 degree in horizontal, 2 degrees in vertical, so that's nothing significant. And then the beat SPV, so if I chose a particular beat, what that would be. And then if you go under the test tab, you would have the list of all your tests. So this is telling you test date and time, head shake, head straight, the check mark in the vision denied column. So this little symbol is vision denied. Now let's talk about head shake interpretation. So head shake nystagmus can have central or peripheral etiologies. It is said to be sensitive, but it's not said to be a very specific test. If you want a more specific test, then you should be doing the head impulse test, because that's really going to tell you right side versus left side, and that is truly a peripheral test. In patients with a unilateral loss or imbalance between the ears, nystagmus is present and usually beats towards the better ear, which subsides after about 30 seconds. So once you stop the head, the nystagmus would run about 30 seconds. If you had a poor ear that's on the left side and a good ear that's on the right side, the beat should be beating rightward. So they're going to beat toward the better ear. This nystagmus may be followed by a second episode of nystagmus that is weaker, subsides more slowly, and beats towards the poorer ear. So in that case, in the case I gave you, it would beat towards the left ear. Typically, horizontal head shaking produces horizontal nystagmus, and rarely does it produce vertical or torsional nystagmus. In the literature, it says if vertical nystagmus is seen, then that could be an indication of a central disorder. And in patients with normal limits or have symmetrical bilateral vestibular loss, nystagmus is absent. So as long as the two sides are performing the same, then you will not see nystagmus. If there's an imbalance between the left side and the right side, then you're more likely to see nystagmus. So conditions with abnormal head shake would be a unilateral vestibular disorder, such as a vestibular neuritis or an acoustic neuroma that's affecting one side. And then here's a couple of references regarding head shake. The first one is from 1907, and that's the very first one, Barony article. And then we've got some more recent ones from 2004, and then Dr. Haynes from 1987.